Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of cervical adenocarcinoma, HPV-independent, gastric-type, that metastasized to the ovary. This is a case of a 40-year-old female patient who presented with cervical mass. And as you can see here from the scan power magnification, the mass is really occupying the whole thickness of the cervical stroma. On intermediate power magnification, as you can see, that we have here well-formed glands with some sawtooth appearance that are lined by cells with abundant clear cytoplasm. On a slightly more higher power magnification, as you can see again here, the glands with very small, minimally atypical nuclei, but what is really very characteristic is the voluminous cytoplasm. And on higher power magnification, as you can see, a large amount of cytoplasm and a well-defined cytoplasmic borders clearly separating one cell from the other. This is very characteristic actually of this type of a tumor. Again, you can see here the very well-marked cytoplasmic membrane, and then we have the sometimes clear, sometimes pale acidophilic, as in this case cytoplasm. But the most important thing is the large size of the cytoplasm. And in addition, we have in this particular case a very small, minimally atypical nuclei that are basally located. Importantly, when these tumors invade, they invade with minimal or no desmoplasia, and this is where really the trick becomes extremely important to recognize these are as a tumor glands, a tumorous growth, because of the lack of desmoplasia, which might be tricky, and some people might really not pay attention to the extreme invasiveness of the tumor going deep into the wall because of the lack of the desmoplasia. Also, please note that there are no mitotic figures and no floating mitoses or basal apoptotic figures, as you would expect with adenocarcinoma that is HPV associated. Again, the tumor, these very bland looking glands are really going very deep in the stroma of the cervix. Again, just to emphasize that these are not usually associated with desmoplasia. Now, sometimes in some of the glands, you might start to see some degree of pleomorphism and some prominent nucleoli. This does not negate the diagnosis. Still, the case would be signed out as the same as a gastric-type adenocarcinoma. And here we have a contrasting between both components. The first component I shared with you with the very small nucleus that is basally located, the voluminous cytoplasm, the well-defined cytoplasmic borders, and then here with the more basally still located nuclei, but more pleomorphic nuclei and prominent nucleoli, but we still have this voluminous amount of the cytoplasm. And please note that in general, there is a lack of mitosis and apoptosis. Lymphovascular invasion is extremely common. Something like 50% of the cases would show lymphovascular invasion. And in this case, we have the vascular space, and then we have the tumor cells attached to one side with the wall of the lymphatic space and growing inside. Now, one important clue and very helpful actually stain to perform in order to support the diagnosis, at least that there is the gastric type differentiation, is the PAS combined PAS Alcian blue, especially stain, and the gastric type carcinoma is usually positive with the PAS with the neutral mucin. Why is that? Because gastric type carcinoma shows pyloric type of differentiation, and these usually contain neutral mucin, and neutral mucin is usually positive with PAS. This is in contrast to the normal endocervical cervical glands which contain acidic mucin, thus they are positive with Alcian blue. So normal cervix would show positive staining. Normal endocervical glands, the mucin would be positive with Alcian blue, so they would show this purple kind of color, while with the PAS stain, with the gastric carcinoma, gastric-type adenocarcinoma of the endocervix, the PAS stain usually stains the neutral mucin like the normal stomach, and would show this exact color that is very helpful to support the diagnosis. This is the gland, one of the glands that I shared with you that does not show the desmoplasia, and this is the PAS stain of the same gland, just to give a whole idea how the diagnosis really works and how the special stain really helps in this context. Now, MUC6 immunohistochemistry is very helpful because it shows the cytoplasmic staining in the gastric differentiation in this type of carcinoma. Normal endocervical cells are completely negative, and this is another focus where we have the higher grade nuclear tumor cell nuclei, but still that cytoplasm shows the granular positivity with the MUC6. P53 in most cases would show this mosaic staining pattern. However, it sometimes can be positive. So the final diagnosis in this case in the cervical component is well-differentiated adenocarcinoma that is HPV-independent gastric type. Now, the patient a few months later developed a pelvic mass that on imaging was found to be cystic and mostly was thought to be originating from the left ovary. So she underwent left oophorectomy, and as you can see here, we have this mass that is composed of proliferation of and lined by the spaces the mucinous epithelium, and on higher power magnification the exact same appearance as we saw with the cervical adenocarcinoma, perhaps not the very well differentiated component, rather the component with the slightly enlarged nuclei and prominent nucleoli, and again here basally located nuclei with the voluminous amount of the cytoplasm and with the prominent nucleoli. And please note also that is still lacking the mitosis and the apoptosis. PAS Alcian blue again confirms that the mucin within the cytoplasm is a neutral mucin of gastric type, pyloric type, similar to the cervical type, to the cervical carcinoma, and the MUC6 is again positive. This is on high power magnification, so confirming that what is there in the ovary is metastatic from the gastric type cervical adenocarcinoma. Now, P16 was not done in the onto the cervical case, so it was done on the ovarian tumor, and as you can see, this is the patchiness of the nuclear and cytoplasmic staining that we would see with P16 normally. Now, the tumor here is completely negative, which is very well described in gastric type adenocarcinoma. P53 again shows this mosaic staining pattern, which means that this is wild type staining pattern. Now, some cases might show some staining with CDX2. Again, this is not widespread, but you have to pay attention that if a mucinous carcinoma in the ovary stains with CDX2, this doesn't mean that this is of metastatic origin from the colon, I mean from the GI, and we have always to keep in mind the possibility of gastric type adenocarcinoma metastatic to the ovary, especially if we have this large amount of cytoplasm. So essentially, these tumors stain very similar to gastric carcinoma. The final diagnosis in this case in the ovary was metastatic gastric type cervical adenocarcinoma that is HPV independent. So remember that this type, a special type of adenocarcinoma of the endocervix, shows features that are very similar to pyloric cells within the stomach. This is why it's called gastric type adenocarcinoma. Remember that these tumor cells show abundant cytoplasm, sometimes clear, sometimes faintly acidophilic, as in our case, and the the nuclei might be very low grade or higher grade. This still is within the context of the diagnosis. Remember that these tumors usually deeply invade into the cervical stroma without eliciting much of desmoplasia. This does not rule out the diagnosis. Actually, this same entity is what used to be known as adenoma malignum or minimally invasive adenocarcinoma of the endocervix. Remember that Alcian blue PAS stain can be very helpful in supporting the diagnosis. And remember that these tumors have a potential or to metastasize to the ovaries. And if especially this was the primary, the ovarian mass was the primary mode of presentation, if you see tumor cells with abundant cytoplasm with well-defined cytoplasmic border, just keep in mind that this might be coming from the cervix in the form of metastasizing HPV-independent gastric adenocarcinoma. I hope you find this tip useful in your daily practice. Thank you.